At the outset, I thank Raju Chaudhary sir for giving me this opportunity. Most of the advancement in cataract surgery is occurring either in the phaco technology or in the IOL. And I suppose the technology is advancing towards smaller and smaller incisions. We have newer injectors, we have newer IOLs. Now let's see what are the advancements which are occurring in the multifocal IOLs. Nothing to disclose. The biggest disadvantage of monofocal posterior chamber IOL is presbyopia. Sometimes we see that the patients were happy before cataract surgery as they had a nuclear cataract and the vision was perfect for near. But later on they find that you are deprived of them by using their near vision by removing the cataract. Now most of us, they are unhappy with near vision, particularly intermediate vision after cataract surgery. And intermediate vision has become important, particularly for those who are using mobiles. And after COVID, I suppose, we have forgotten to see the distant object. The quality of vision required for near and the intermediate is the most important thing while working on the computers, while navigating on the car, during reading, or mobiles, tablets and all. The options which are available for near vision correction after cataract surgery are monovision, but they have their inherent problems like loss of stereopsis, bifocal glasses. The cosmesis is a problem, particularly in young patients, multifocal IOLs, accommodative IOLs, and the recent ones are intermediate, monofocal IOLs with enhanced intermediate visions. The monovision, the one eye is made myopic and other one with normal vision, that is preferably with no glasses. The myopic eye is usually non-dominant one, but there is loss of depth of perception and the binocularity is also lost. Accommodative IOLs, they came in the market very fast and they disappeared also. It's monofocal, pupil independent, no rings in the center, so no halos and glare. But due to contraction of the capsule, the near vision usually do not remain for a long time. So the long-term visual outcome is a problem with accommodative IOLs. Multifocal IOLs are useful particularly for those patients who desire of spectacle-free vision. This is a problem because they cost a lot, and the cost is a problem particularly in the post-operative period if the patient is unhappy with multifocal IOLs. No retinal pathology, no gross cylinder, but gross cylinder can be corrected if you implant toric multifocal IOL, accurate intraocular lens power, which is stressed many times, and of course it is important, perfect surgical procedure. But they have their problems also, loss of contrast and glare and halos. Less now mostly in the recently developed IOLs. Now if you see the evolution of the multifocal IOL, it is from split bifocal, that is upper segment for the distance and lower one for the near. Now no one uses these IOLs. Refractive IOL, it has got concentric rings or zones, and they have zones for the distance as well as for near. These IOLs are dependent on the pupil. If there is small decentration of the pupil or small decentration of the IOL, there is always a problem with the visual outcome. Diffractive multifocal IOL, they are perfect for distance and near, but the intermediate vision is a problem. And a spectacle, particularly for the younger ones, and glare and halos could be a problem in these IOLs. Newer generation IOLs, that is trifocal IOLs, they have extended range of vision, and the optimal visual acuity you can obtain for the distance, near as well as intermediate vision. Initially we started with multifocal IOL with add of 3.5 to 4 diopter in the center. But the intermediate vision was a problem. Excellent result, most satisfied were hyperopes and particularly those housewives. But the intermediate vision was a problem in these IOLs. Now the development of trifocal IOL with low AD, there is a flexibility of using IOL according to the patient need. If the patient is putting near objects at a distance, you can have low near AD. If they are using the objects for near, close to their eye, then you can add more for these IOLs. The advantage of this IOL is diffractive zone, that is, they have less dependent on the pupil size and the lighting conditions. Smaller diffractive zones compromises on near and intermediate performance in low light or in large pupil patients. Larger diffractive zones compromises distant vision in mesopic condition. But with the development of this IOL, there is a maximum light transmission that allocates for the near as well as for distance. That it transmits as much as 88% of the light at 3 mm of the pupil size. And this allocates half of light for the distance and half is split into near and the intermediate vision. There are various types of IOL which are available. How does light utilization matters? It impacts contrast sensitivity and quality of vision. More the light transmission, better the quality of vision at all distances and the excellent performance. And as far as material is concerned, we prefer hydrophobic compared to hydrophilic material because of less PCO and the biocompatibility of the IOL, and there is refractive predictability in these IOLs. Excellent long-term outcomes are possible with the hydrophobic material. Your surgery has to be perfect. You can stain the capsule with the help of Trifam blue and perform Rexis the way you want. And whatever procedure you are following for the removal of the nucleus that you can do, may it be a stop and chop or direct chop, whatever. But your procedure has to be perfect, cortex removal and the implantation of intraocular lens. Make sure that the loops are well placed inside the bag and the capsule Rexis covers the optic of the IOL. Thorough viscoelastic wash is also important. Now there are other lenses which are available. Those are the extended lenses with extended depth of vision, and those, they don't have rings. The best part is that they don't have rings, and the glare and halo is not a problem in these IOLs. But sometimes if the patient is reading at a close distance, they may need some near vision corrective glasses, maybe lesser than what we give in our routine cataract surgery, maybe add of plus 1.5 to 1.75 diopter. Now these are the new IOLs. These are presbyopia correcting IOL, non-diffractive monofocal IOL, extended depth of focus. The one of them is the VVT1 from Alcon. No split of light, therefore excellent distance and intermediate vision and a functional near vision, but the cost is exorbitant. The mechanism of action of this IOL, they have a small central ring, and the central ring is one part of the ring is slightly elevated and a smooth plateau. The elevated part gives the near vision, and the smoother part gives the slight curvature part give the intermediate vision. The another one is the Lucidis IOL. I don't have experience about this IOL, but just to complete the list, is available. It is a refractive one, hydrophilic one, and a pseudo non-accommodative IOL. The light distribution is uneven in these rings, the 52% for the distance and 23 and 25 for near and the intermediate vision. As far as Indian scenario is concerned, you have to spend...
Rajesh, just summarize, please.
Yes. You have to spend more chair time, and ideal patient selection is crucial. The technology is expensive, but with the Indian IOLs which are coming up, they are no more expensive. The cost of surgery has gone down. But you have to deal sometimes with unhappy patients also, in spite of good surgery. and how to avoid these unhappy patients, improve biometry, correct astigmatism, precise fit IOL, perfectly fit IOL, and well-centered IOL, that is very important, and improve the corneal surface. Thank you all.